Hello everyone, this is Dr. Christian O'Neill. This is a video for the infectious disease training that the substance use disorder counselors in San Mateo County need to do each year. It may be applicable in other counties as well. But we have a lot of material. I'm going to try to keep it to an hour. When this is done, there is a DocuSign link that I'm going to send out where you can verify that you saw this. So, okay, we got a lot of material, so we're going to jump into it, all right? So let's start, and I'm trying to focus on conditions that we see commonly with our patient population, okay? So we'll start and another thing, I'm going to move pretty quick because there's a lot of material, so some screens I'm just going to skip right through, but in any case, we'll start with MRSA. I'm sure most of you have heard of that. Methicillin-resistant Staph aureus is a skin infection. It usually starts as a skin infection that's caused by a staph bacteria that is resistant to many, but not all antibiotics. The symptoms of MRSA, they start off as swollen red bumps that may resemble spider bites. Bumps can be warm to the touch. They can be full of pus. And if it goes on untreated, a fever can develop. These bumps, if they're untreated, can become abscesses, which can be problematic. If the infection goes untreated or the abscesses become too severe, then clients can become bacteremic, which means the bacteria gets into the bloodstream. So this is usually how it starts. You can see there's pus inside of that big one for sure. The complications of untreated MRSA are, well, it is a skin soft tissue infection, but bacteremia, as we talked about, endocarditis, which is a bacterial infection of the heart. You can have MRSA pneumonia. Bone and joints can become involved. It can get in the central nervous system, which would, of course, be a problem, and they can also develop shock and sepsis. All right, so the treatment, if they just have an abscess, it can usually just be incised and drained. And that's really the only treatment that's needed. But oftentimes, we give oral antibiotic therapy if there's extensive skin infection, if it seems to be rapidly progressing, if there's any sign at all of systemic illness that we just talked about, if there are any comorbidities, diabetes, HIV, that sort of thing, if the person's very young or very old, and if the abscesses are in an area that's difficult to drain. So there's still plenty of antibiotics that can treat MRSA. Clinda, Bactrim is a common one, tetracycline. In terms of the hygiene, if they have an abscess that's drained, we just got to keep the area clean and dry and bandaged. They'll oftentimes have to return to clinic and have the abscess packed again with gauze. Anyone that has MRSA should avoid sharing items with other clients infected due to possible transmission of the bacteria, so razors, clothes, anything like that. Someone who has an active infection, we can encourage them to be mindful of their hygienic practices using hand sanitizer and that sort of thing. There are decolonization efforts. They're not always successful, but for someone who has had recurrent MRSA infections, one of the things is to use an antibiotic inside of the nasal passages, and they can also take dilute bleach baths or use a topical antimicrobial agent such as chlorhexidine. We don't use oral antibiotics for decolonization only. It's only for an active infection that we use those. Here's just the dilute bleach baths are probably not going to be very practical in treatment, but that's how they're done. There's a recipe for that. We don't really need that, I don't think. In terms of the risk for transmitting to other clients, as long as there's not a sharing of razors, clothes, linens, that sort of thing, then there's really a pretty low risk of transmission. So it's okay to keep people in treatment that have an MRSA outbreak while it's being treated. Scabies is another common public health issue. It's caused by a mite that gets under the skin and burrows under the skin and begins to lay eggs, and then the mites begin to multiply. Transmission occurs through direct skin-to-skin contact, so there's really not transmission commonly through sharing of clothes and linens and that sort of stuff. However, we're very careful to not do that, but it's typically actual skin-to-skin contact, and it needs to be about 15 or 20 minutes of close contact. The people with scabies present with a generalized rash throughout the body. It's often worse in between the fingers. It's usually the face and the neck are usually not affected. This is what it can look like. Let's say between the fingers. It can have this linear appearance as the little mite burrows through. The treatment's pretty simple. They use permethrin cream. It's applied to all areas of the body and kept on for a minimum of 8 hours. They can keep it on for overnight if they like, and it can be reapplied in 1 week also. We need to remind the patients they're probably going to continue to itch for up to 2 weeks even after effective treatment. There is an oral anti-parasite medication, but we don't really use that often. In terms of keeping the rest of the clients safe, we can wash and dry their clothes by themselves in hot water and in a hot dryer. And any items that can't be washed, we can quarantine in a plastic bag for up to 72 hours. So these patients do not need to be discharged either, as long as we practice these containment measures. Okay, another infectious disease that's pretty common is pneumonia. Pneumonia just means a lung infection. It's usually caused by bacteria or virus. The infection can affect one lung or both lungs. And the symptoms depend on the infective agent. Bacterial pneumonias are generally quite a bit worse than viral pneumonias. So this is a lobar pneumonia. It's just obviously confined to the one area on the left side of the screen in the right lung. That's probably a bacterial pneumonia, though, which means this person's actually probably sicker than this person. This chest X-ray looks worse, but this is probably a viral pneumonia. It's affecting both lungs. So pneumonia symptoms: cough productive of mucus, fever, shaking chills, shortness of breath, rapid shallow breathing, chest wall pain often made worse with inspiration. You can have a fast heartbeat, feeling tired or weak. There's several bacterial agents and viral agents that cause community-acquired pneumonia. There are different agents that cause pneumonia inside the hospital. But strep pneumonia is kind of the most common bacterial pathogen. It's also the most serious one. And there is a pneumonia for that, or excuse me, there is a vaccine for that. The most common viral pneumonia, I don't know if it's the most common, but influenza is something, of course, we see every year. Influenza virus during the winter months, patients usually present with a sudden onset of fever, a non-productive cough, which sort of distinguishes it from like a bacterial pneumonia where there's a lot of mucus being produced. People with the flu have a cough, but it's usually non-productive. And headache is another very common symptom, and sore throat, which kind of make it look like influenza over a pneumonia. Over a bacterial pneumonia. So the flu, as many people know, it's spread by tiny droplets when someone coughs or sneezes or when they talk, and these droplets can be inhaled by people nearby. It can be picked up from the surface of objects, but it's less common. The incubation period by the time someone catches the virus until they start having symptoms is somewhere between 18 and 22 hours. Although they can start spreading the virus up to 24 hours before the symptoms onset, and some period from 5 to 10 days after the onset of symptoms. They can still be contagious to others. So complications of influenza, if they get sick with the flu, then it makes it more likely they could get a bacterial pneumonia. Worsening of chronic medical conditions, particularly like COPD or congestive heart failure. The high-risk groups are people with COPD. Their lungs are already vulnerable at that point. Chronic liver or kidney disease, young and very old patients, pregnant women, sickle cell patients, because they're already kind of immunocompromised. Oftentimes, sickle cell patients don't have functioning spleens anymore, and the spleen is an important immunologic organ. And then clients that are otherwise immunocompromised, HIV positive, or clients that have had organ transplantation. So there are rapid flu tests that diagnose it, though it's usually a clinical diagnosis. It's the right month, the symptoms are right, and even if the rapid test is negative, we oftentimes will go ahead and diagnose it as viral influenza. The treatment is really just symptomatic. There's no real treatment for the flu. They do have medications like Tamiflu, which you've probably heard of, which can be used to decrease the severity, but most people need to have been symptomatic for less than 2 days, and as we said earlier, oftentimes there's the incubation period of up to 72 hours, so it can be hard to get it on board quick enough to really make a difference. So I don't think that Tamiflu is a major part of the management of flu. It's usually just over-the-counter medications and time. Prevention, of course, the flu vaccine is recommended for children older than 6 months of age and everyone older than that. The other recommendations are obviously staying away from people who are sick, covering coughs and sneezes, and frequent hand washing. So for our purposes, unless someone is really at risk for decompensating themselves, they have other comorbidities, heart failure, COPD, etc., we're really not going to be able to discharge everyone that has the flu. And it is contagious. But what we can do is provide masks, provide adequate counseling in terms of covering their mouths, coughing and sneezing into the crook of their arm rather into their hands, and using the antibacterial, antiviral hand gels. Okay, so I think the mask and the good hand hygiene in covering the coughs and sneezes, that's really what we need to emphasize during flu season, so we don't have it spreading around through our residential programs. Okay, tuberculosis, another lung disease. It's the most common cause of, it's the most common infectious disease-related condition in the world. The World Health Organization estimates that 2 billion people have latent TB, while another 3 million people worldwide die each year of TB. So somewhere around a quarter of the world's population has latent TB, and the countries with the highest prevalence are Russia, India, Central Asia, Central America, that sort of stuff. About 10 to 15 million people in the U.S. have latent TB. TB declined since the early 20th century because of infection control practices, but in the mid-'80s there was a resurgence in TB, primarily because of the HIV epidemic. And also the TB bacteria started to develop resistance around that time. After peaking for 25,000 cases in 93, most recently, 2018, we had about 9,000 cases of TB reported. About 70% of them were from non-US born people. And about 13% of the U.S. cases were recent transmission. So thinking is that a lot of people perhaps immigrated to the U.S. with active TB. That's certainly a possibility. Okay, so TB flourishes wherever there's overcrowding, poverty, those sorts of things. Anything that weakens the immune system will increase the risk. Diabetes is sort of a low-grade immunocompromised state for a lot of people if it's poorly controlled. Alcoholism is also malnutrition, chronic renal failure, the elderly. So those are the people that are at risk. And also, again, the poverty, overcrowding, living under bridges, those sorts of places. That's why a lot of our patients come to us who do have latent TB. They've been exposed in those environments. So humans are the only reservoir for the tuberculosis bacteria. It doesn't have any animal hosts. Similar to the flu, it's transmitted by airborne droplets when someone who has active TB, not latent TB, but active TB coughs. Someone nearby can inhale the tiny droplets, and then an infection can begin in the second person. So if someone, there are really three main fates that would happen if an individual were next to someone with active TB and inhaled the droplets with the bacteria. So the first thing is, if they were a healthy person, they would inhale the bacteria in the droplet, and their immune system would just kill the bacteria, and they would never have any consequences of it at all. So it's very possible that an intact immune system can destroy the bacteria as soon as it's brought into the body. Another thing that's actually very common, which leads to the latent TB infection, is that the bacteria is inhaled. They start to multiply, but very quickly the body mobilizes its immune system, and these alive TB bacteria are sort of walled off by the body. It's a thing called a granuloma is formed. It's fibrous tissue that surrounds the bacteria. And the thing is, when a granuloma is formed, those bacteria are quarantined, and they're not going anywhere. These are the people that have latent TB. They can't spread TB to anyone else, and they're probably not going to ever develop TB themselves. But the thing is, the TB bacteria can live for decades and decades inside of that little granuloma. So the risk is that if down the line that same individual ever became immunocompromised, they developed HIV, their diabetes got way out of control, they needed an organ transplantation, and so they were taking immunosuppressant drugs, then they could develop reactivation disease. Okay? The last fate is that it can happen, even to healthy people, you could inhale the bacteria that was aerosolized in the air, and you could develop primary tuberculosis. That does happen. So those are the three main fates. Number one, body kills the bacteria right away, and you'll never even know you had TB. Your body surrounds the bacteria inside of a granuloma, and you develop latent TB. And again, you can't spread it to anyone. And then the last one is that you could develop primary tuberculosis, which is less common in healthy people. So we just said that the most of the time, the asymptomatic latent infection is what happens, okay? So if let's talk about just a little bit more about what it looks like when the granulomas form. So a healthy person inhales the bacteria, they start to multiply, the fibrous tissue is formed around it. That initial site of infection is called a gone focus, and that gone focus over time will become calcified and just becomes a calcified nodule inside the lung. There it is on the left side of the screen. That was someone that inhaled the TB bacteria. It started to multiply. The body formed the granuloma around it, and they would have had latent TB. These are why we oftentimes get the chest x-rays once a year to make sure that gone focus, or if it's old enough, it's a calcified nodule, isn't changing. As long as it's staying the same year after year, then we know their latent TB is not progressing at all. So we'll go back to the incidents when someone actually develops active TB. What does that look like? So people with active TB are sick. It's not going to be a very subtle presentation, at least not if they've had it going for a week or two. It's a very significant cough. They sometimes they can be coughing up blood. They can have chest pain with breathing and coughing. They begin to lose weight. They're fatigued. They have fevers, night sweats, chills, loss of appetite. So again, people with active TB are quite ill. Again, people with latent TB have no symptoms at all. They're not contagious, but they will always have positive PPD tests. So we'll talk about the PPD test. Everyone's had one. They just take a little bit of the tuberculin material injected under the skin, and if you have a reaction, then we know you've been exposed to TB, that you have latent TB. One problem is that not in the US, but in other countries, in Russia, for instance, they do have a vaccine against TB. It's called, BCG. And we don't use BCG in the US. Apparently it's not that effective, but they use it in other countries. And someone that has had the BCG vaccine will also have a positive PPD. So we're not able to distinguish between latent TB and a history of having a BCG vaccination just by using the PPD test. So that's why there's serum tests. The quantiferon is kind of the most common one. And that one, if that one's positive, then you have latent TB. It doesn't matter if you have the BCG vaccine or not. If the serum quantiferon test is positive, it's because you're exposed to the tuberculosis vaccine. So that's what the PPD looks like when it's placed. Now, you'll see there's a lighter circle and then a fainter circle and then a darker one in the middle. When we measure it, we only measure that hard, darker part in the middle. The surrounding area doesn't count in terms of the measurement, in terms of determining whether it's positive or not. So the more at risk someone is, the smaller the area needs to be in order to be positive. So if that darker circle in the middle is only 5 millimeters across, it would be positive if the person was HIV, if they were in recent contact with someone we know has active TB, if they've had a history of organ transplantation in the past, or if they have chest x-rays which show that maybe an old gone focus or an old calcific nodule has progressed into if it's changed in any way. So 5 millimeters or more is positive in that cohort of people. 10 millimeters or positive is 10 millimeters more is positive in people from recently arrived from high prevalence countries, which we talked about earlier, IV drug users, residents or employees of high risk settings, which includes us, I think, and people that are at high risk for due to other conditions, diabetes, long-term steroid therapy, which makes someone immunocompromised, leukemia, end-stage renal disease, etc., and in little kids. And for everyone else, just normal, healthy people out on the street, that circle that we measure that shows that there is a reaction has to be 15 millimeters or more, and then it's considered positive in everybody. Again, in that outer circle, that can get as big as it. That's just a reaction to the material. It's not actually a immunologic reaction to the TB proteins. So, but again, we just measure that hard part in the middle. So we want to treat latent TB in everyone because there is a chance that it could evolve into active TB down the road. Again, if their diabetes got out of control, they became HIV positive. So we want to encourage treatment of latent TB infection. There's a bunch of different regimens. There's 9 month, 6 month, 4 month, 3 month. The issue with the 9 month one is obviously compliance. A lot of people don't finish it. So, these shorter regimens are probably, the compliance is better, but there can be some liver toxicity with them. So, but there are some choices available in terms of the length of treatment. Okay, we will switch over to viral hepatitis. There's lots of different causes of hepatitis. But since this is infectious disease, we're just going to focus on the viral causes that we see most commonly. Of the viral hepatitis, there's A, B, C, D, E, F, and G, probably. A, B, and C are the most common. We're really going to focus on B and C, however. There are vaccines that are available for hepatitis A and hepatitis B. There is not a vaccine for hepatitis C, which is probably what we see most commonly in our patient population. Blood transfusion used to be a risk for this, but it's not any longer, really due to the improved screenings. So acute viral hepatitis. Again, we're just going to focus on B and C now. Okay, so acute viral hepatitis really looks the same in any sort of viral hepatitis. The symptoms are fatigue, flu-like symptoms, dark urine, light-colored stools, fever, jaundice, yellowing of the skin and eyes, right upper quadrant abdominal tenderness. All right, so this is called icterus, actually, when the whites of the eyes become yellow. And obviously, this gentleman on the right side of the screen is pretty jaundiced. Of all those, the A, B, C, D, E, F, G, etc., B and C are the ones that cause the chronic hepatitis mostly. Hepatitis E can also, but primarily we think of a chronic viral hepatitis with types B and C. The symptoms are oftentimes mild and nonspecific for many years. It's really not until they progress into severe liver damage, cirrhosis, liver failure that we start to see the really significant manifestations of chronic viral hepatitis. And we'll get back to those in a minute. So we'll specifically talk about hepatitis B. Hepatitis B is really a huge problem worldwide. About 350 million people are chronic carriers. Most of those are in Asia. And the issue with it is that there's a very high prevalence of perinatal transmissions from mothers to their fetus. And so that's why a lot of babies in Asia are born with hepatitis B. And when they acquire it that young, they almost always become a chronic carrier themselves. If you acquire it as an older child or as an adult, there's over a 90% chance that your body's going to fight it off, actually, and you will not become a chronic carrier. But for neonates and little babies, there's a very high likelihood that they will become chronic carriers. Hepatitis Hep B in the United States, there's about 850,000 people currently with chronic Hep B, about 3,000 cases a year, new cases, though that figure is debatable also. They suggest that there might be more than that because of low reporting rates. But in any event, it's significantly less of an issue in the U.S., and that's because of the vaccination program, because there is a vaccine for it, and it's given out very, very commonly in the U.S. So about 5,000 people per year and about 250,000 people worldwide die from chronic hepatitis B each year. The transmission is through the exchange of bodily fluids, including blood, sex with an infected partner, injection involving shared needles, as it could be birth to an infected mother. We talked about that earlier. Needle sticks are a common cause for healthcare workers, and sharing items such as razors can also lead to Hep B transmission. So if symptoms occur, they usually begin around 2 months after exposure. It's a pretty long latency period there. Symptoms can last for several weeks, but up to 6 months. The fatality rate is quite low. It's less than 1%. So people that develop acute hepatitis B, they can get pretty ill, but there's a 99% chance that they're going to survive, and there's a greater than 90% chance that their body will fight it off to the degree that they'll rid themselves of the of the virus, and they will actually become immune. So most people that are infected with hepatitis B will develop natural immunity, and that doesn't happen with hepatitis C, and we'll talk about that. So if someone does have acute hepatitis B, what it can look like is anorexia, nausea, vomiting, fever, muscle aches, fatigue, changes in the taste and smell sensation, right upper quadrant pain. It can become encephalopathic. That just means that when the liver is inflamed, one of the jobs of the liver is to metabolize the ammonia that is produced through protein metabolization. If the liver's not functioning right, that ammonia builds up in the body. And most of us that work in residential treatment have had someone who's encephalopathic. They have cirrhosis, or they have hep C or hep B chronically, and they can become delirious, altered mental status, that sort of thing. And if it becomes significant enough, hepatic encephalopathy can proceed into coma. So the most common treatment for that is lactulose. A lot of our patients with cirrhosis and hep C are on lactulose. It's a medication that they take, which it's kind of a syrup, and they drink it, and it allows the body to rid itself through the stool of excess ammonia. So whenever we have our patients come in with lactulose, we know that they have pretty advanced liver disease. So we talked about this. So, about over 90% of people that develop hepatitis B, at least as an adult, are going to fight it off, and then they're going to become immune. We talked before, the infants are really don't have that robust immune system, so it's a very high likelihood they're actually going to become chronic carriers. And as we get elderly and have other medical comorbidities, that also increases the likelihood that we will be unable to fight off hepatitis B and develop that natural immunity. So chronic hep B symptoms are very similar to chronic hep C symptoms: fatigue, anorexia, nausea, right upper quadrant pain, hepatic decompensation leading to the encephalopathy, and eventually development of cirrhosis and or liver cancer, which is hepatocellular carcinoma. Antiviral treatment for people with chronic hep B is it's available, but it's not it's not overwhelmingly effective. So unlike the new advances in the hepatitis C treatment, which we will talk about, liver transplantation is really the only viable option for people in the latest stages. Hepatitis B HIV co-infection is very common. So about 70 to, let's say 80% of people infected with HIV in the US have had evidence of past or current infection with hepatitis B. They may have had the virus and cleared it, or they may have chronic hep B, but it's a common co-infection to have. The main issue with the co-infection, if someone has HIV and hep B concurrently, then they worsen each other. The HIV means that the hep B will progress more rapidly. There's a greater likelihood that they will progress to liver failure or liver cancer. And the other way around too, the hepatitis B will make the HIV more difficult to treat. Hepatitis C, it's less common worldwide than hepatitis B, although I think it's actually more common. It is more common in the U.S. than hepatitis B, and that's because there's not a vaccination for it. Somewhere around 2% of the U.S.'s population, or of the U.S., is positive for hep C antibodies, which means they've been exposed. About 3 out of 4 people that are positive are also carriers of the virus. All right. So just to kind of pause here for a second. So healthy individuals, if you contract hepatitis B as an adult, there's it's about a 95% chance that your body's going to fight it off. You will not have hepatitis B, and you will be immune from hepatitis B. But that rate is much less for hepatitis C. Somewhere around 20 to 25% of people will fight off the hepatitis C virus and will not become a carrier. But that means about 70 to 75% of people that contract the hepatitis C virus will become a carrier. And the other thing is, even that 20-25% that fight off the virus, they don't develop immunity to hepatitis C. So they could be exposed and get the virus again at another time. So there are about 30,000 new infections in the U.S. and somewhere around 10,000 people die from acute, but mostly chronic Hep C each year in the U.S. So for the new infections, about 60% are with IV drug users, about 20% are sexually, 10% are other causes, occupational, perinatal transmission, that sort of thing. And there are no identified factors in about 10% of the time. So people with chronic hepatitis C, the risks are similar to Hep B, that, the end stages are cirrhosis and hepatocellular carcinoma. Most people with chronic hepatitis C will go for several decades without really being impaired. But, somewhere around 25, 30 years, that's when they really start to develop the impaired liver functioning. Okay? And it is the most common indication for liver transplantation in the U.S. Okay, we talked about this before. Needle stick injuries and razors, tattooing, that sort of thing. You can transfer the virus by those means. So acute hepatitis C is the first 6 months after infection. And what's different about Hep C is really about 2/3 of the people really have no symptoms at all, or the symptoms are so mild they don't even know. And that's another reason why Hep C gets spread around so easily. A, there's not a vaccine for it, but B, people with acute Hep C oftentimes have no idea. They just don't feel bad, or if they do, they don't imagine that it's because they've they have the virus because it's so mild. So acute Hep C goes unnoticed in most people. If they were to do blood tests, sometimes between 1 and 3 weeks after the infection, they could pick up antibodies, or they could pick up actually some viral proteins in the blood, and somewhere between 3 and 15 weeks they could pick up the antibodies to the virus. We talked about the viral clearance rates. Again, that's the percentage of people that actually clear the virus, so they can say they no longer have Hep C, and it's somewhere around 20% of people. Okay, so symptoms of acute hepatitis C are really the same for any acute viral hepatitis. Fatigue, nausea, vomiting. They can become jaundiced, right upper quadrant pain. Lower extremity edema would be pretty severe, but that can certainly happen. And with all acute hepatitis, there can be some itching, and that's because as the bilirubin is metabolized by the liver also, similar to the ammonia, and if the liver is not functioning, if it's inflamed and it's offline, then the bilirubin builds up and it deposits in the skin. And in addition to causing jaundice, it leads to itching. So this chart here just shows kind of the exposure history. So the top upper left, let's say 100 people are exposed. You kind of just somewhere around 15%, 15 to 20% will clear the virus. They do not have hepatitis C. But again, they're not immune. They could still get it. And somewhere around 80, 85% will develop chronic hepatitis C. They will become carriers of it, if you will. About 80% of those people will be stable. 2-3 decades will go by, and they really won't have any complications. But about 20% of that group will proceed rapidly into liver decompensation. It can happen over a matter of years, just a couple of years. At times, they can move into cirrhosis or hepatocellular carcinoma. And ongoing alcohol use and or HIV co-infection will accelerate the decompensation that occurs with hepatitis C. So people that continue to drink can expect that are also hepatitis C positive can really anticipate that they're going to have a much more rapid progression. They're probably not going to be in that group that goes 25, 30 years before they really see any of the chronic hepatitis C complications. So we talked about this before, the spontaneous clearance rates. Women slightly have a better likelihood of that happening than men. If someone does get actually very ill from the acute hepatitis C, that will actually increase the likelihood that they're going to be among the group that clears it entirely. So in a weird way, if you contract hepatitis C, you'd be better off actually having a pretty significant response to it, getting a right upper quadrant pain and jaundice and that sort of stuff. It really shows that the immune system is mobilized in a sense. If clearance is going to happen, it's going to happen within the first 4 to 6 months usually. If it doesn't happen after that, then it's probably not going to happen. You're probably going to be a carrier if you haven't cleared it. And again, unlike hepatitis B, even if you do clear the hep C, you are not immune to it. So chronic hep C, the group of people, and again, it's about 80% of those exposed who have the virus persisting for more than 6 months. It's usually going to be asymptomatic for a very long time. But again, they're always going to be at risk for developing overtime cirrhosis and or liver cancer. Chronic hep C symptoms, when they do start to appear, maybe 20 years down the road or more, fatigue, flu-like symptoms, joint pains, itching, sleep disturbance, appetite changes, nausea, depression, similar to chronic hep B. When the disease really starts to advance, they get the mental status change because the ammonia is building up in the blood. They can develop lower extremity edema, ascites when that fluid builds up in the abdomen. They can be vomiting blood due to veins inside of the esophagus, which become weakened. And they're also at a risk to bleed because an impaired liver is unable to make the necessary blood clotting factors. So bleeding out due to an esophageal rupture is a common cause of death for people with cirrhosis, whether it's from alcohol or from hepatitis C. And I think most of us have probably had a patient, at least in residential, that has had the ascites, the fluid that builds up in the abdomen. And oftentimes they have to go get it drained a couple times a week. Hep C and HIV co-infection is also very common. Somewhere between 1/3 and half of people with HIV also have Hep C. And very similar to Hep B, having HIV will accelerate the clinical progression of Hep C into the end stages of cirrhosis and liver cancer. And having HIV positive also increases the likelihood of perinatal transmission. Mother to fetus transmission of Hep C is less common than mother to fetus transmission of hepatitis B. Don't know why, but it's true. Hepatitis C treatment for a long time, up to the last 5 or 6 years, it was interferon and ribavirin, which is an antiviral used for hepatitis B, and the results weren't very good. There are different genotypes, different species, if you will, of hepatitis C, and interferon really only worked well on one of the genotypes, and it happened to be the less common one in the U.S. Genotypes 2 and 3, it worked pretty well on. It didn't work very well on 1, and 1 is the most common one in the U.S. And even when it did work, it was somewhere around 1/3 of people cleared the virus. This is with the old interferon ribavirin protocol. And that went on for like 9 months to a year. You had to take it, and people felt really bad. They felt like they had the flu the whole time. They were fatigued. They got depressed. There were skin complications, lung, GI, neuropsychiatric complications. A lot of people just couldn't tolerate it. They just felt too bad. And if they were already depressed, that was a reason to not give it to them to begin with, because people became suicidal. So some advances were really needed. And in the last 10 years, these new hepatitis C medications have been developed, and they really have revolutionized it. And it's really been in the last 5 years that these medications have become accessible. So now most of us have probably had a Hep C patient that has had these medications and has eradicated their infections. So Sovaldi, Olysio, those are Harvoni, those are kind of some of the more common ones. But yeah, it's really revolutionized it. These 93% eradication rates, 97%. So Hep C is very treatable now. And that wasn't always the case. All right, so now we'll talk about HIV. In 2017, the most recent data, about 37 million people worldwide living with HIV. About 20 million of those were actually actively accessing antiretroviral therapy. About close to 2 million new cases worldwide in 2017. About close to 1 million people died in 2017. 77 million worldwide have become infected, and 35 million people have died in 35 years, something like that, maybe a little bit more than that. So HIV in the U.S., about 1 million people are HIV positive. Unfortunately, about 15% of them, they suspect, are unaware of it. Close to 40,000 new diagnoses in 2017. That's been stable over the last few years. Close to 16,000 people died in 2016 from HIV-related causes. And for new diagnoses, of the 40,000, about 6% of those in 2017 were due to IV drug use. So this just shows kind of the age breakdown for the new diagnoses of HIV. Most prominently at 25 to 34 years old. The most common subpopulations that are affected are African American males that have sex with other men. That's the most affected group. And see how it breaks down after that. Okay, so risk factors for exposures. The most risky sort of behavior is still unprotected receptive anal intercourse. So out of 10,000 exposures, 138 people will actually acquire HIV in that manner. And you can see sharing needle sharing is the second most common, about half as likely as the sexual means of contracting it. So an acute HIV infection, what does that look like? So it's like a mononucleosis type syndrome that usually occurs sometimes between sometime within 2 to 4 weeks of acquiring the virus. The symptoms are fever, lymphadenopathy, swollen lymph glands, often in the neck, sore throat. It can be a diffuse rash, joint aches, muscle aches, diarrhea, headaches. These symptoms are going to last somewhere between 4 to 8 weeks, and then they're just going to go away, and people are going to feel just fine. So again, it can be kind of a mild illness that's unconcerning to people, and then they start feeling better, and they are unaware that they've actually acquired the HIV virus. The initial stage immediately after contracting HIV is known as the eclipse period, and there are no laboratory markers. They would be negative if they had an HIV test, and it's in that period when they're oftentimes most contagious, actually. So that early stage accounts for somewhere between 10 to 50% of all HIV transmissions. When they have the acute hepatitis, or excuse me, the acute HIV syndrome that we talked about, which is sort of a almost like a long, somewhere 4 to 8 week period of feeling fatigued and maybe like you have some flu symptoms. That's when they're a very high likelihood of transmission also. And when you couple that with there's a window in the beginning where even if they had a blood test, they would come out negative, you can see why the early stages of the HIV infection are the most concerning in terms of spreading the virus. So if someone were completely untreated by HIV, which just doesn't happen in the U.S. often. I don't know what it's like in the rest of the world, but most people have access to care in the U.S. They would still probably live around 10 years before they would succumb to opportunistic infections or malignancies. Because people don't die from the HIV virus. Their immune system becomes so compromised that they die from lung infections and different types of cancer that are actually uncommon in people that have healthy immune systems. So, as many of us probably know, the CD4 count, the T cell count, is kind of the main marker that we look at when we're trying to determine how someone's HIV is being managed. So the CD4 cells or the T cells are kind of the main cells that fight off infections. Normal people have around 1,000 cells per millimeter cubed, and HIV patients usually have less than 1,000. When HIV becomes AIDS, it's when the T cells have dropped below 200. Okay, so T cells are just a very important part of the immune system. The HIV virus specifically affects the T cells, and when the T cells get so low that the immune system is not able to function anymore, that's when these opportunistic infections and malignancies start to show up. And once the T cell count drops below 200, then we would say someone who has HIV, we'd say now they have AIDS. The other condition for receiving a diagnosis of AIDS is to have an opportunistic infection. Your T cells may be actually above 200, but if you have any opportunistic infections, which include these, the first two, Mycobacterium avium complex and Pneumocystis jivaricii, are or lung infections, toxoplasmosis. The third one is usually a central nervous system infection, and also different types of unusual cancers are known as AIDS-defining illnesses. So whenever a patient who's HIV positive has any of those, that's when we say they've transitioned to AIDS. Kaposi sarcoma is that skin cancer that a lot of us are familiar, or at least you've seen it on, seen it in a movie. Those purple lesions that can be on the mucosal surfaces of the mouth or really anywhere on the body. But that's an AIDS-defining illness also. So HIV management, the laboratory testing includes the CD4, the T cell count, checking the serum for the viral load of the virus itself, and they can actually take the virus and do some drug resistance testing. And oftentimes people need to change up their medications over time. They can't keep taking the same medication year after year. But the CD4 count, the T cell count, is kind of that's the main measurement that we look, and it's the best predictor of prognosis. The treatment has changed so much over the year that it really is a manageable chronic disease. Oftentimes people that are getting early suppressive antiretroviral therapy have near normal life expectancies and much fewer morbidities in terms of inflammatory conditions that we used to see. There used to be like HIV-related dementia and that sort of stuff. So the treatment, we don't cure it now, but it's managed to a degree that it's a manageable chronic disease. At least it's considered to be so. Screening for it, the U.S. Preventative Task Force recommends that everyone 15 to 65 years old be screened, unless there's some risk factors that show that they should be screened at an earlier age, but 15 to 65 are the recommendations for HIV screening. The ways of screening now, there's laboratory tests. You can go to the hospital or the clinic and have a serum test, which really approaches 100% accuracy, and the tests are available in 1 or 2 days. There are all sorts of rapid HIV tests available now that are using oral secretions, and those are also extremely reliable. They can be ready. You can get them back in 5 minutes, actually, these rapid tests, but they would still need to be, a positive test would need to be confirmed with conventional testing. Here are just some other ways, just some of the confirmatory tests. They're looking for particular proteins and antibodies against HIV or HIV RNA. So a positive rapid test means go to the hospital and get that confirmed. Pre-exposure prophylaxis, this is something we're seeing more and more of. I know I see it on a lot of our patients' med lists. People that are at high risk are now getting antiretroviral therapy prophylactically to prevent the infection. These programs require that the participants also receive counseling concurrently, and they provide easy access to condoms and encourage medication adherence. And they take the medication they really use is Truvada, and it's once a day. So some of our people that come in when we see these medications, particularly when we see Truvada, it used to be that it's because they were HIV positive, but now if you see Truvada, it may be prophylaxis. They may be part of a pre-exposure program. So harm reduction, the studies show that it's effective in preventing the transmission, but there's also a lot of difficulty adhering to the regimen. They don't really take the medication as prescribed often. So, it's useful, but there's certainly some issues with the programs. The recommendations to be included in a PrEP program or to be at high risk, if you're an IV drug user, that's mostly what we're seeing, or if you're a sex worker, if you have a partner who has HIV, and but you have to be obviously HIV negative to be in a PrEP program. And they agree, again, to receive the counseling and to have repeat HIV testing every 3 months. Okay, that is it. I don't know how I did on the time. But yeah, if you have any questions, I know I moved kind of quick. If you have any questions at all, you can email them to me. Most of you have my email. And also, as I said, I will send out a link that uses DocuSign that you can complete. Just add your name to it and send it to me, and I will sign it and send it back to you, and that will verify that you watched this video, that you completed the training, When I send it back to you, you can print it up and give it to your program director, and they can include it in your file. Okay, so it'll demonstrate to the county that you completed this. All right, great. Thank you so much for your attention. Okay, take care. Bye bye.